Good afternoon. Welcome. It is the June 25th episode of the THCB Gang. And despite the fact there's a whole lot of chaos going on this week, and my favorite football team is playing right now live against the Lygeia, and my children are screaming next door, we have a great show lined up for you. All right. Wow, it is loud in this house. Starting off today, we have on the gang, Kim Bellard, who is the former editor of Tincture Health. Sarab Jha, Rograd, radiologist and assistant professor at the University of Pennsylvania. On the gang, rather than behind the scenes today, we have Zoya Khan, THCB's editor-in-chief. And then regulars, Vince Caratis from Grand Poobah at Better Health Technologies, and my old boss, Ian Morrison, health futurist, late of Institute for the Future, and these days still involved with Strategic Health Perspective at Levitt Partners. And then dragged in last minute, my co-host from Health in 2.0 and the host of WTF Health, Just a Massa. And with that, we are going to get going. Afternoon, everyone. I think everyone's well. Ian, if you block your ears, I know you're recording. Chelsea are actually winning. It's nearly half time. We're beating Man City 1-0. So if you find I'm not paying attention, it's because the game's got exciting. They're about to blow for half time. Yes, the English Premier League is back, as we discussed last week. And what else is back? COVID-19 seems. I guess it never really went away, but it seems to be back. So. Love to get a couple of comments about what you've noticed this week. And I suspect, Kim, I'm going to start with you because you're now the king of TikTok, at least in our generation. Tell me what you've noticed the last couple of weeks.
Well, it's got to be the increase in cases. Things have been seeming to calm down, but now things are starting to create or out of control. So it's going to be scary about what's happening with this still first wave.
Rob, what have you noticed?
Oh, quite a few things. If it was some other abnormal time, every week would be like one piece of news that would be historic and a book would be written on it. But now we just get attuned to it one after the other. A very interesting thing that came out this week, which I think a lot of us suspected, was that in the beginning of the pandemic, around February and March, lots of thought leaders, influential wonks, not only said that wearing masks is selfish, but also useless. Some went as far as saying it's absolutely no sense whatsoever wearing a mask if you're not sick. And it turns out to be one of those famous last words, like mankind can never fly, that type of famous last words. But it turns out that it was for a noble cause. The lie was for a noble cause. And as Anthony Fauci admitted, it was to prevent people from taking away masks, which would be diverted from healthcare workers who would need it. I think it's noble. I do like noble lies. In Hindu mythology, Lord Krishna used to come up with a lot of noble lies, but he was a bit of a cunning guy, that lad. But I don't think it's going to be seen that way by many people. I mean, I kind of even applaud it. I think, oh, that was good, but it would be nice if you didn't admit it. That's the whole idea of a noble lie, is that it's a lie. And it's precisely the fact that it's done for a noble cause, which infuriates people even more. So the mask fiasco is going to continue, unfortunately.
All right. Jessica, what do you notice in the last week or so that's
Now I've got to add fiascos of the things that I'm tracking, because Matthew, I have a list of crises in healthcare, tsunamis in healthcare, and now I've got to add fiascos.
You have broken health parts of health.
And how many different ways the healthcare system is broken? I've got a running list. Yeah, we're up to like 11 different crises at once here. So we've been watching, Matthew, you and I have been watching on Health in 2.0 some of the funding deals. What's going on there? It's still a lot of money going toward mental health companies. We've had a couple big, since the last time I was on, I think Headspace raised about $50 million. Big Health, which has Sleepio for insomnia and Daylight for something else. They raised about 40 million. So a lot of focus still there. Remote care has gotten a little bit more attention, it seems like, or at least a couple big deals have closed there. So companies like Lygeia Health, which is in the musculoskeletal space, they closed a big deal just this week. Physera got acquired by Omada Health in an attempt for them to continue to platform out over there. And then we've even seen remote care, like a couple startups that drive care to the home. For more serious conditions. So Ready raised about $50 million. Google Ventures was in there. I know you're excited about that one, Matthew. And Dispatch raised $136 million, which is just a monster of a deal. The last big thing I think we've been seeing in that space, Cedar, a medical billing company, startup that's supposed to help. What was it, Matthew? It's like the part about health, our healthcare in this country sucks, and this is taking advantage of how sucky it is. I think it's like something along those lines is what you said that their business model is basically. So they raised $102 million this week just to take advantage of that situation. The other thing that's happening in health tech is that everybody's got their eyes on what's going to go on with the public health emergency. So I interviewed Livongo's government affairs VP, Leslie Kistein, and she was talking about, those favorable regulations and reimbursement policies that have been put in place for telehealth and remote monitoring. She gave us the scoop on that. And it turns out that the public health emergency that's made those favorable has got about a month left in this 90-day segment. So Azar can extend it, but the rumor was that in Tulsa, Trump was going to end it. And she said that that was flying around Capitol Hill for the last couple of weeks. And so it's interesting that he didn't. I wonder if, Kim, if your TikTokers had something to do with that, and the fact that he didn't have a big enough crowd to make that proclamation, because it wasn't because he was looking at the case numbers increasing, because blind to that, right? But interesting to see what will happen from the health tech side with those reimbursement policies and regulations once that public health emergency ends, because the telehealth stuff, the key takeaway, the telehealth stuff requires literally an act of Congress, whereas the remote monitoring stuff, HHS and CMS have typically had purview over those types of policy. So that's what's going on. Lots to keep our eyes on there.
Okay, well, that was quite a.
Sorry, yeah, you had a lot
I like
to say.
it. All right. Vince, what did you see in the last week?
Well, hey, hi, Matthew and all. Matthew, you've quit before that. I'm coming from the wilds of Idaho. So rather than show you my virtual background, I thought I'd show you the true wilds of Idaho, my home office today. What I'd like to do is challenge conventional wisdom, and I'm just going to introduce a topic that I hope we can discuss a little bit further. The emerging conventional wisdom seems to be that everything is going to be virtual and telehealth. And my reaction to that is not so fast. Okay, I think there's some things that, and I'm not saying that there won't be more of it, but I think whereas the mantra has been to maximize telehealth over the last couple of months, that in the future, the mantra will be more to optimize the balance of home care, or rather virtual care, and real care in hospitals and doctors' offices. So Matthew, you and I have known each other, quite a long time, and have been somewhat cynical observers of the healthcare system. And when have we ever seen the healthcare system organized for the convenience of patients long term? It's been centralized, and we've had patients go to doctors and hospitals, for the benefit of whom, I would ask. The second thing I'm going to point out is that it's becoming clear, and Seema Verma has said this, for now we have reimbursement parity, but that's not going to go on forever. And at some point, it's going to be back in the provider's economic interests to have real visits as opposed to virtual visits. So I'm just introducing a topic. I hope we can come back and discuss a little bit further later on, but I think that there's going to be limits to the telehealth virtual world in healthcare. Thank you.
Yeah, no, I think that's dead right. Zoya, what have you been noticing?
Yeah, so I'm really intrigued to see how the social determinants of health plays into a lot of sort of these care models that are coming out with just this whole propensity and this whole idea towards equitable care across sort of different communities, with Oakland the school board in Oakland just voting out police officers like guarding their schools, and then how the budget's going to be redistributed to maybe some mental health services, counselors and nurses that so many of these, younger kids, younger minorities are in need of versus the policing system. And there was an interesting piece that Adrian Groper did about understanding how systemic racism plays into EMRs on THCB actually a couple of days ago, talking about how a lot of health records don't take into account where certain people live, food access, and they use coded language to describe a patient's behavior of non-compliance. So I'm very interested to see where sort of the funding models are going in that sphere, as well as just recently a company, I'm forgetting the name of it. You just covered this in Health in 2.0 about an LGBTQI. Bloom, yeah, getting some investment to improve LGBTQI plus access to health services. So I'm really interested to see how diversity and communities of color will be changing the whole landscape.
Yeah, I think the key is, can you remember what comes after LGBTQI and whatever else?
Yeah, LGBTQI plus. You always want to be PC about it, but then it's long.
Always trying. All right, Ian, last but not least, what do you notice in the last week?
Well, I mean, I was on last week, so I'm still tracking much of the same thing. I think we cover, these are all great topics, by the way. I'd love to dive in. But I mean, the two big stories obviously have been pandemic, the actual cases and the bounce back, and also the economic numbers not being as great. The IMF's forecast that GNP will be down 8%. All those numbers and the global projections are all worse. And the one thing I've been sort of looking at, following up from last week's conversation about race, to pick up on Zoya's point about inequities, is just again tracking this cascade of impact on jobs, on coverage, and on who's affected. So I went back to my old days of being a real analyst and got out the data and actually did a little spreadsheet analysis on occupation by race, which I'd like to riff a bit on about what the top race, the differences about. It's what we've been saying in a lot of these calls is, it's generally speaking, the people who take the early bus are the ones who are most vulnerable, both either economically or as frontline workers. But when you actually dig into the numbers, it's pretty bloody dramatic. The other thing I hope to put on the table, I agree with all of these comments, is the Blue Cross of North Carolina deal. I'm fairly familiar with North Carolina from recent. The last time I got in an airplane actually was to speak in North Carolina. So I'd love to hear your views on all of that. And the telehealth subject, I think is very important, that conversation. That's enough to begin. Oh, and masks. Yeah, Rob, totally agree. I may have said this before, but when I was a wee boy in Scotland, as I couldn't wait to get home from Sunday school to take off my kilt and put on my Lone Ranger outfit. And I'm just completely bummed that a Lone Ranger mask is completely ineffective at either preventing COVID getting it or giving it. So
yeah, it's probably works if you're out in one of those protests. It may set off make the face recognition stuff, not work as well.
Oh yeah, there's some benefit to it.
They don't watch enough Lone Ranger and Zorro. Was it Zorro as well?
Zorro had the mask.
Yeah, no, they both had the same mask.
Well, they all had the mask coming from the top of their head, not the bottom of the
Wrong side, guys.
wrong level of mask.
Yeah.
It's more like, I was going to bring up Ian stole my son. I was going to bring up the Blue Cross North Carolina piece, but just to be clear for those who haven't seen the news, what they're saying is they're going to help support primary care. And Ian and many others on these calls and the gang shows have been saying, hey, what was the fact that the insurance companies got all this money? They kept getting the money. The elective procedures and the visits went away. So the hospitals and the primary care docs didn't. The hospitals basically got huge tranches of money handed out by CMS. May not be enough to cure what's been going on with their balance sheets, well, with their revenue. Their balance sheets in general are pretty good. I've been doing some tracking of that, but the primary care docs have really been suffering. So Blue Cross of North Carolina said they're going to help the primary care docs, but there's a sting in the tail. Well, not a sting. There's a it comes with conditions. The condition is they're basically going to start moving them off fee for service on to capitation, essentially, and they're even going to help Eldaid, which is one of the companies, rather than by Farzad Mostashari, one of the companies has been helping primary care docs sort of figure out how to become an ACO and take capitated payments. So a lot of us in the sort of wonkish community think that's a great idea. I'm not sure every primary care doc is quite ready for it. So it's going to, it comes with conditions. And I think that to me, that kind of encapsulates, what Vince was talking about, what Ian was talking about, and perhaps we can start there.
Yeah, if I can comment.
Yeah, please do.
I think the COVID crisis is really potentially realigning power dynamics among the players in healthcare. The hospitals have clearly financially taken it in the shorts, and the revenues are down dramatically, and CFOs are worried about making bond payments. Health plans have done pretty well, and I think the other emergent player to watch is the tech companies. So I think we're going to see realignment, and I would say what's going on in North Carolina is probably representative of health plans either starting or continuing to try to better align themselves with physicians, and that this is very likely to come at the expense of physicians being aligned with hospitals. Hospitals have bought up physician practices. That hasn't gone so well. We'll see what happens in the future.
Ian, Kim, jump in on that, because you've both been looking at that a long time.
Yeah.
Somebody.
Well, let me jump in on yeah, I agree with all of that. The only add I'd say, Vince, is that it may not be just health plans, it may be employers. I mean, I spent some time last week with PBGH's board, and I limited what I can say publicly because they haven't announced a lot of things that they were discussing. But one thing they have been very public about is their concern over primary care and the sustaining of primary care practices, and also actually to the point of lobbying Congress to put a moratorium on the acquisition of primary care practices by either health plans or health systems at this time. So this North Carolina announcement, I think, is a step in the right direction. I would point out that North Carolina, is in a very interesting confluence of characters. Patrick Conway was there for a while, obviously, and we all know that story. He's now with United, great guy. Mandy Cohen, who worked for Andy Slavitt's chief of staff, is the Department of Health secretary, and I spent some time with her when I was back there in January. And is a great leader, and I think has been a champion. Roy Cooper, the governor, has been a champion. The North Carolina Hospitals Association have been very supportive of value-based agenda. The Margolis Center at Duke, where Mark McClellan is, has been very supportive. So there are a confluence of stakeholders in North Carolina that have pushed that agenda. How to replicate that in other places it requires a similar confluence of leadership, and I'm not sure it's going to be as easy to pull off. I'd love to see it, but I think it's going to be tougher to pull off.
They've also got a pretty big monopoly system. Then I'm blanking on. Used to be called Carolina's Hospitals, and now it's called.
Well, it's Carolina's or Atrium.
Atrium now it's called. Yes, that's the same name as the place.
Yeah,
but
and it is concentrated, and there are some larger progressive systems with decent leadership who are trying to do the right thing.
I'm curious, do we think that COVID is going to cause more primary care doctors to want to join hospital systems as sort of a safe port in a storm, or is it going to drive physicians away from hospitals because they're finding that it's not so good? And we talk about primary care physicians, but what is it? More than half of them are owned by physicians, by hospitals.
I have a little rant about this, because if you look at the status, I mean, so when I was learning healthcare under Alan Hoban and then under Ian Morrison, the idea was you put everyone to a what is now called an ACO, or was then called an integrated system, or was then called a capitated health plan, and you figured it all out, and you shook out the system. You got rid of a bunch of specialists in hospitals, and you added a bunch of nice capitated primary care groups. And in Southern California, I remember we went down and met them in the 90s. There were a whole bunch of them, and they kind of are still alive. CareMore's still around, and health.
Someone wants to apologize for.
we have our own Zoom bombing, and it was naked. But that that lasted only so long, right? And then you ended up with hospitals essentially buying, and there was a great paper by Bob Kocher and some others in the New England Journal a while back, showing that hospitals were losing money on every single primary care doc they were buying. So that tells you, well, why were they buying them? You know, there must have been a reason. It was because they're using to fill the beds and fill the cardiac the cath suite, the cath lab, and the keep the imaging machines spinning, right? So if you take that point of view, today's news really struck me. It's an old company called Paladina Health, which does direct primary care, and they've signed up to be direct primary care practice for Common Spirit, which is Dignity, the Catholic chain, and the one they merged with in the Midwest, which is now the biggest Catholic chain. And I go back to my point. I said this a lot to some of the startups, some of the VCs. You always go on about getting your tech companies to be ready to, to service the big hospitals. I mean, you probably disagree about this one. To service the big hospitals is their future. But if we really, it's to say, Vince, what are the tech companies going to do? If we really wanted to change healthcare, we would get people who wanted to replace the big hospital systems. Now, sounds to me that so Paladina going to work with Common Spirit. This reminds me of Amazon saying in 1996, well, we're going to go and help Barnes and Noble sell more books. That wasn't what they said, right? That wasn't their intention. And I don't think if the co-opting, there could be leadership within the system. But if all this innovation that we're seeing gets co-opted, we'll end up back where we were, because I don't believe there is, perhaps Vince, you can come back, and Sarabi can chime in. I don't believe there's much incentive if you can get back to normalcy, if you can get back to enough, enough procedures, enough fee-for-service business. Why would you want to go for the hassle of really doing primary care-based capitated payment systems? Strikes me as being very hard work.
What I would be watching for, I expect that even hospital systems are going to come out and finally bite the bullet and begin to recognize that we need to move to more value-based care payments. Their financial motivation now becomes simply needing revenue stability. And let me throw out kind of a what if. What if Amazon were to acquire a large telehealth company? I think the scenario I see very possible is that the hospital no longer is the front door or the digital, or they lose the positioning of being the digital front door to primary care, and therefore essentially all care, and they lose control of truly, we won't be calling them integrated delivery systems anymore.
Years ago, I wrote a piece that said that the problem that we have is hospitals are trying to be department stores. They've got departments for everything, and they control everything. What we really want them to be is malls that have a bunch of different people operating within them, and they just provide real estate and overhead, and have independent doctors and medical practices and groups and so on practicing within them. But that model never happened. The hospitals got bigger and bigger.
I think one of the lessons hospitals should be learning is you don't need to own the components of the delivery system, especially as the world now is becoming more connected and data is beginning to flow. What you need is control over the data network, but it doesn't mean you need to own the physical assets.
I mean, you say that, Vince, but they've been incredibly successful doing that. I literally have been building a spreadsheet, which I won't share on the screen because I just go to a podcast, but taking off some work that was done on Healthcare Dive by Samantha Liz and some others. But if you look at the reserves of some of these big systems, I mean, I know they've been losing money. I know things have been rough in recent years, but just, for some of the, just to take off the top of my head, UPMC is $11 billion sitting in cash or in the stock market. Trinity has got $8 billion. Providence somewhere around 10. Ascension has got over 15 to 18. Some of the bigger, Sutter's got around 6. I mean, some of the bigger AMCs like Stanford, UCSF, Stanford's got $2.5 billion sitting on its balance sheet. UCSF, got 3.7 billion. It strikes me. Mayo's got over 11. What you're talking about is a substantial shift away from model, in which they've done very, very well. Right. And it goes back to the arguments that the policy wonks, which I think includes most of us on the call, have been talking about. Well, let's change the way that hospitals get paid, and let's think about primary-based care. Zoya was talking already about let's take away money from the police budget and use it for mental health in the community. And it strikes me, it's hard to suggest that that's going to happen. Now, yeah, the threat of Amazon building Amazon Care, which already exists, for their client, for their employees in Seattle, they already have primary care and telehealth and home care, and as Jess said, you've got people like Dispatch and Ready who be you can send people to your house. You've got the sort of infrastructure starting to get built there. I struggle to believe that the current set of hospitals are going to figure out anything other than wanting to go back to normal. I mean, maybe I'm wrong, but please argue with me, somebody.
I'd love to hear from Sarab about, on the ground, what's happening, because, everybody I'm talking to in the delivery side is trying to get back to normal on electives, and notwithstanding what's going on. And that I do think that the issue that was raised by Vince about the relative mix of telehealth versus in person, it's going to come back towards where we were. It's not all, but there will be a new normal. But I'd love to hear, Sarab, what you're seeing on the ground in terms of the recovery of electives, and whether or not any of the digitization efforts that were taken for a COVID world are persisting and sticky in the return to normalcy.
Yeah, so what is apparent in my theatre is imaging, and not just imaging, the indication for imaging. So if imaging is being done for preoperative evaluation, that means the operation for which it's being evaluated is coming on the rise. And I can tell you that slowly we're getting back to the pre-COVID era in terms of the frequency, in terms of the indication, which tells you that lots of things that were done in the pre-COVID era that had been suspended is now coming back. I don't know if hospitals as a whole have looked at this COVID era as some sort of wisdom into how they should operate in the future. At the moment, they're thinking we just need to make sure everything is back to normal. Let's recover our losses, or put it another way, get patients back who needed the service who didn't have them. And I suspect that's going to be going on for a while. In terms of the actual, change in model for payment, as Vince suggested, deep down, everybody realizes, every single person realizes, I would say, at least most, that the system we're in today is setting us up for some sort of gigantic failure. If it wasn't on this occasion, it may not be. It may be. So we're in a fragile payment system. Fee for service is a fragile payment system. It's a circular type of argument. It's not robust. It's not resilient. And value-based payment is likely to be more resilient. But who's going to be the first one to say, yes, value-based payment for me? And if there were genuinely value-based payments, I think primary care could have much more power if they had some authority over where and who and how much the funds would go, as they do in the UK. So to make primary care more relevant, you have to sort of give them access to the purse.
I think you're really pointing to a very important dimension. Do we just say we're interested in value-based payments, or do we really, as a system, embrace it? And what I see is maybe the number is a quarter, something less. Probably, Ian, I'm curious in your take, but North Carolina seems to be a place where they've really embraced value-based payments. Whereas most of the rest, 3/4 of the world is still, well, we'd rather keep things the old way, or they have been that way. I don't know that will be the prevailing thought once the dust settles around COVID. But Ian, what do you observe?
Well, I think the one leverage point is this issue of are self-insured employers waking up to the value of primary care, and are they willing to change their behavior? Because in large measure, they've been the problem, right? I mean, value-based care is a purview of managed Medicaid and managed Medicare. And self-insured employers have been, they've played around with ACOs, but a lot of it is pretty bloody half-hearted.
Yes.
And so, but those self-insured employers control the entire margin of the health system. So if they act, they have an ability to do this. And I've been sort of cheering them on to do something and take advantage of this opportunity. But I completely agree. I mean, look, Matthew, we've been doing this for 40 years together, or 30 years. You don't, what you really need are lives and doctors, right? And you should be able to buy the rest of the stuff in the spot market. The problem has been orchestrating that in an effective way. And Kaiser's one version of that. Optum is one version of that. But absent embracing of that model by the commercial payer, the self-insured employers, we have defaulted to the power of these large integrated delivery systems. And look, I mean, I know they've got a ton of money, but I mean, I sit on the board of a hospital. I'll tell you, what you look at days cash on hand, 10 billion sounds like a lot in Mayo, but that's 360 days of cash. That's a lot, but when you get under 150 days of cash, that's when you start freaking out, because it doesn't take much to go sideways. I mean, these things eat money in terms of cost.
Yeah.
And by the way, just one other final point on this. If you talk to hospital CEOs, the number one fastest growing item on their balance sheet or in their operating line pre-COVID was the subsidy to physicians' income for both the primary care and specialty doctors they own. Now they make it up on volume as one. I go to the Palo Alto Clinic, and before I was lucky enough to go on Medicare, my doc was doing telehealth and all that kind of stuff and answering phone calls. I never had to go in. That's probably why I'm in such miserable shape. But anyway, a friend of mine was on the board, and I said, "Why are you guys, how do you get paid for me? Because I'm a self-insured individual market person on a fee-for-service basis. How the hell do you make money if I don't come in?" And he said, "Oh, we're just trolling for invasive cardiology, right?" So, I mean, that's how but seriously, that's how it's worked. It's worked on facility fees. That's why you want to get Rick Pollock really ashen. You'd say site neutrality is in place, and that freaks the AHA out.
Yeah, and that's the idea, of course, that if you don't have, if you're a hospital, you can charge more than if you're a doctor's office, even though it's the same service delivered in basically the same place after you change the name.
In the same building.
In the same building, exactly. That's good. All right. Let's change. Sorry, go ahead.
I was just going to quickly add, just off of Vince's point, and Ian, actually to your point as well, about sort of these telehealth services. I think what's really going to drive change, especially in healthcare with the newer generation coming in, is convenience and what they're going to be paying for. So we've seen examples like Nurix, Lemonade really be picked up in sort of the millennial generation of, ordering your birth control or ED medication or, all of those online, and it's all just the convenience of it. And I think really if providers can figure out that piece is how to conveniently deliver care, like an Amazon or like, one of these larger e-commerce sites, that healthcare becomes sort of like an e-commerce trading sphere. I think that's gonna be really important, especially when you're serving healthcare to millennials and Gen Zers as they're coming in and getting more and more involved. Just a quick point on that.
Yeah, and it's not just Gen Zers, right? Because we had Grace Codovano on here a couple of weeks ago talking about her mum now, being serviced by this, and I think that's a new way of doing it. And so I agree.
So
one more point on the hospitals.
Kim, then Vince.
So we can't forget that it's a political problem, because in almost every community, the hospitals are, if not the largest employer, certainly top 10, and on their board, they've got other people that are either rich or big employers. So they have way outsized political clout. And anytime we want to make a rational, healthcare change, you have to run into the headwinds of the political pressure that they're able to bring to bear at both the local, state, and national levels.
Vince.
So I agree with your point about convenience, but the question I will pose is, I think the hospitals risk that being their domain. What if again, the scenario of Amazon buys a telehealth company and they provide the convenience, or Optum, gets into telehealth in a much bigger way, and they leverage that and own the primary care physicians. Huge potential realignment in the healthcare system in the offing.
Yeah.
Well,
I'm shocked Optum hasn't already made such a purchase.
well, they've done some, and so I want to be interested, because a couple of things that are related to this, but sort of orthogonal, is Ian's talking about what are employers doing. One of the things, you had an interview with Ginger a while back,
Yeah.
about the growth in the use of mental health services. Some of the other stuff, we did a talk for that mental health conference
Going digital behavioral health.
Thank you. I can remember the name of this conference. So I made two people put on, which everyone is everywhere in the sort of upstart digital health flavor of mental health, and a really great online conference. The question is, what do you think is really going on in that employer base? How are employers dealing with the COVID crisis? Because there are multiple facets to that. So what do you think?
Are you asking me?
Yes.
Oh, well, well, what I think, it seems to me like the least expensive, easiest thing to implement is some sort of a digital health something. And I mean, mental health is, I think, where we're seeing, I think you're seeing a lot of employers, if they haven't already been buddied up with a telehealth company that's providing primary care, or the low acuity care. It's like those types of things, I think, are what we're starting to see happen right now. I mean, I think, was it Target that just rolled out Doximity to everybody that's on its plan, in order to help kind of you're making a face at me, Matthew Holt, but I
can't remember, it's Doximity or DoxyMe, because there's a company called Doximity and a company called DoxyMe, both doing the same related thing around
right.
health,
But so yeah, I mean,
no, it was Cirrus MD. I remember, it was a different one.
Cirrus, you're right. It was Cirrus. Sorry. So I mean, you're seeing a lot of these big employers, I think, try to make some sort of partnership arrangements with some of these companies that are providing virtual care, or providing digital health services in lieu of what could be provided in place. But I feel like I'm skeptical myself on this. And so you've got your spreadsheet where you're tracking, Mr. Holt, the hospital financial data, and I'm tracking, like, how many customers do some of these digital health companies and telehealth companies, what are some of these numbers that are out there? Because, I'm obviously very much, in support of taking the technology and using it to help, kind of fix the things that are broken in the healthcare system. But, it's like, if this stuff is not, if it does not become ubiquitous now, I don't know when the conditions are going to be more right for it. I mean, we are in a situation with forced demand. In a lot of cases, you have to go digital first, because it's just, it's safer, or whatever the health system that you're part of, or the health plan you're part of, is pushing you in that direction, due to the pandemic. But when these things change, and when some of these, the reimbursement at parity, when that goes back, if that goes back to the way it was before, what's going to happen to some of the increasing use of telehealth or virtual care that we've seen moving forward? I'm not sure. And I think maybe the employers will be the group that it sticks with, but I don't know how much of that, and maybe, I don't know if you guys can weigh in on this from your perspective, how many, large self-insured employers need to be, bought into something before it has enough sway to impact the traditional health system and change the way the incumbents operate?
Yeah,
I'd have one point on top
Everybody.
of that. But the other thing is, if you're expanding dramatically in low acuity telehealth and in mental health, right? So some of the rapid increases, there's a lot more depression, anxiety, and low acuity mental health. We're not talking a lot more sort of schizophrenia and PTSD, although that may be emerging in my house at any moment. But the question is, does that actually replace anything? Or is that more trolling for invasive cardiology, that Ian's talking about? And at what point do the employers say, that, so, we've added these nice bonuses because our people now need them, versus we're actually changing the way we're thinking about delivering care overall and going to sort of the system that Vince is talking about? I don't know. I mean, that's very much up in the air as to whether, if you do a lot more depression screening, a lot more visits with social workers and what have you, does it make any difference to the actual big health cost spend? Sorry, I interrupted Ian and Kim and Vince, about 5 other people. So.
Well, I was just going to violently agree with something Jess said about.
I'll take your violent agreement anytime.
That's right. I mean, if I was running the world, here's what I would say to employers. I'd say, look, a lot of you are scrambling around, some would say flailing around, buying these point solutions that are disjointed and bespoke, and all the startup guys like to hold up as, oh wow, we sold this to somebody. What they ought to do, in my humble opinion, is create a digital health formulary and agree that this is the game, and they need to massify their firepower and agree on, here are the 5 companies that we're going to support in these various spaces, and that's all. I mean,
well, if they did that, me and Jess wouldn't have a show. So
yeah. No. I know it's kind of cruel and Stalin.
CVS Health tried to do just that. They created that digital formula. It's got the worst name I've ever heard. It's like Point Solution something. It's terrible. Yeah. And then Express Scripts also did the same thing, where they've kind of pulled together what they've deemed best in class. I've heard nothing about how that's going. I would love to know if somebody out there is watching and has any information on how that stuff is going. I'd love to know. But Ian, go ahead. Sorry.
No. I mean, look, it's the reason these things break down is that employers haven't had the discipline to act in concert and massify, right? They just, I've been doing this with them for 30 years, and it's my frustration. My only point is just watch, because they are in a position where they are very concerned that because of the Empire Strikes Back on the provider side, because of the likely consolidation post-COVID as weaker players capitulate, that the pricing power is going to be on the provider side massively. And they're the ones who are going to be asked to make up the hole that the health system, or that COVID dug for the health system this year.
Ian, I want to express a friendly devil's advocate perspective here.
Why are we being so friendly? Come on.
It's friendly. So,
I got violently agreed with. That wasn't quite so friendly. I thought I was going to get hurt at first.
Agreement is less friendly,
but in a friendly way. I'm not so sure I see the employers as much of a pivot point. I mean, there's clearly a group of 150 or 200 large activist employers in the country that have really have formed coalitions, and they've been at it for, I don't know, 20, 30 years. But as a percentage of the total employees in the US healthcare system, and then you got to add to that the number of people who are unemployed, they just aren't part of that massive movement. And, I have the counter movement has been where employers just really want to get out of healthcare. Let somebody else take this over. And, I think that movement will come back in this scenario.
Well, you have to remember that most employers use health plans to administer their benefit plans. But
they're self-insured.
Go to TPAs, but large ones typically go through a health plan. They hire a Highmark or a CVS or a Cigna or someone like that. So they're still beholden to what the health plans are doing.
So I think there's a bigger point here, right, which we should move on to. We got about another 15 minutes to talk, and I want to get onto some of the big picture issues. And I'll preface this. I'll start by saying, we've had a hell of a week of politics, right, where COVID's coming back, the unemployment situation, which the V-shaped recovery seems to be in doubt if it ever was a V-shaped recovery. And the data, I mean, it's very early days, right? We're in late June. November is a long way away, but it looks like Biden is way ahead in all the swing states. And it looks like the Democrat primaries either elected or got close to electing a bunch of sort of progressive lefty AOC types, rather than the sort of more state right wingers. I didn't see the final result in Kentucky, but it was certainly much closer than they thought it was going to be to take on McConnell. So I don't know, but I mean, strikes me you could imagine that you have this situation going on. You also have the situation going on where we still are talking about unemployment dramatically increasing, Medicaid rolls, going to be increasing in all states where they've expanded. what the hell happens in those swing states where take North Carolina, right? Didn't expand Medicaid until it got just by the skin of its teeth, got a Democratic governor a couple of years back. So to me, there's this question about, is it employers, or are we going to see, a bigger push to a more activist government? I mean, more activist than Biden has been talking about on the campaign trail. So let's just, run the clock forward. It may take a while to get there, but is there going to be impetus in this for pushing for a much more comprehensive sort of Medicaid expansion, Medicaid for all? George Halpern talking about Medicare Advantage for all, or medical advantage, as he calls it, versus everyone's sort of trying to go back to it. Otherwise, as Vince says, we got this huge, Vince said, you got this huge hole where so many more people are unemployed. And although there are some activist employers, they're covering fewer and fewer people. Right, I said a lot there.
I want to on that, saying, like, I think there's a resounding noise of sort of universal healthcare, right? As the Bernie bros or sort of started this whole just this debate. And I think that there's a lot of nuances that a lot of people at sort of the, like you were saying, activist employers don't fully understand and recognize. But there is this whole effort of, universal coverage for everybody, Medicare for all who want it, and I'm curious to see how the more AOC types actually start implementing those policies at either a state level, a governor level, or even in a community-based format. So just a question to answer your question as well.
Keep in mind though that I don't see many scenarios where people are saying that the Democrats are going to pick up to 60 seats in the Senate. They're still going to they may get control of the Senate, but they're not going to get to 60. So the Republicans are still going to be able to block very ambitious bills. So I don't know that we're going to see radical changes in legislation in the near future.
Well, I would agree with that. I think let's just assume the polls are correct and they're sustainable, and there was an opportunity to get a majority in the Senate. So you had House with a small majority in the Senate and the White House in the Democrats' hands. I think under that scenario, I think you could see Medicare Advantage for more. Biden's talked about lowering the age limit. I'll remind us that I think the right number is if you take out 50-year-olds to 64-year-olds, that's 25% of healthcare costs right there. So that takes a lot off the back of employers and has a level set. And it also would hammer the finances of hospitals, by the way, if that was paid in a Medicare rate.
Well, wouldn't it be secondary to employer coverage?
No, if the law said you can move anybody over 50 onto the books.
If you're on Medicare and you're actively employed, Medicare is secondary, not primary.
Right. Well, it depends how the law is written. Yeah, you're right, Kim. It could be written that way. But I guess that's one scenario. I mean, I'm still not, look, Donald Trump got elected when Hillary was ahead in the polls, remember? And I think there is, as we learned from our old colleague Humphrey Taylor, there is a systematic underpolling of extreme right views, I think, in the polling industry. I know there's a lot more xenophobia and racism out there that is not being counted. But anyway, but I think you're right. Under this democratic scenario, there's some expansion and coverage I think would be there. And, I think the longer this crisis lingers economically, because that's the thing I sort of try to introduce at the beginning about who's affected and jobs by race. I'll give you the sort of bottom line. For Hispanics, it's disproportionately construction and agriculture, where over 50% of the jobs in those industries, 67% of drywallers are Latino, right? And so there's a whole thing about the recovery of the construction industry, the safety of meat packing plants, that's another area. For African Americans, it's disproportionately in a sort of civil service jobs on the one hand and service industries on the other, all of whom are vulnerable. If you look at where African Americans are disproportionately represented, it's literally people who are in custodial and other security jobs, as well as prison guards and public employment. And that's the thing that's terrifying, because one thing we know, and I think this is really one of the big stories, is the deficit, even if Biden's elected, is going to be gigantic. And so we may want to do stuff, but we're up against the pokey. I mean, we're talking about budget cuts in California, for God's sake, whether there are no Republicans in California. So
That's right.
How about to Devin Nunes?
Well, he's still here, but he just lost to the cow, so it's possible that it's possible that he's busy on the agricultural front. I mean, but I think that is a thing that's coming, right? So if you have, and it's got ramifications for healthcare, it's got ramifications for criminal justice and social justice and policing, it's got massive ramifications for the environmental policy. If you have the Democratic win that we're expecting, but it's not 60 seats in the Senate, and it's got a bunch of conservative types like the sort of the folks who kind of held up health reform last time in the Democratic Party. It doesn't matter. If you have that, you can have so many demands from the left on to basically say we went kind of moderate in the Obama years, but really we want to go to universal coverage, we want the Green New Deal, we want all this stuff. That's going to be, and if you look at younger Americans, as I keep on bringing up, polling wise, they look much more like Danes and Swedes than they do, well, they're not Swedes, than they do like, the old white guys, even if the old white guys are now disgusted with Trump because he thinks they all want to die and is prepared to have them, go and instead, vote for Biden if they don't care. So I think that's coming. But as Ian says, it may not happen. They may not win the Senate. The Democrats may not win the Senate. They may not win the House. They may not win the White House. And you could end up with this scenario which is pretty unpleasant of massive deficits, states in real trouble, no real help from the feds, and Medicaid kind of having to expand, but the only way they can do it is by cutting rates. I mean, there's a lot of unpleasantness potentially ahead, even if we don't decide to borrow another 2-3 trillion or whatever it is from the
politically. It may be better for the Republicans if the Democrats win, because then they're going to have to inherit the mess, increase the taxes, and then in 2022 and 24, the pendulum will swing back and they can blame the Dems on all the mess.
Is this
Matthew,
just an opportunity for Walmart here in healthcare? Is this what they've been gearing up for the whole time with their little walk-in clinic with the prices printed on the wall and everything that they've partnered up with up and down their supply chain? Is the moment now for Walmart? Is that what we're saying here?
You might argue that. I mean, they're in the right place. Right?
Honestly, I think if change is going to come, it's not going to be because of the government. It's not going to be because of the incumbents. It is going to be one of these retailers. It's going to be either Amazon or Walmart, who has an idea of how to get people the stuff that they need as quickly, conveniently, and inexpensively as possible. And as people are scrambling, waiting for their unemployment checks, and Medicare or Medicaid is doing this or that or the other thing, and they're sick. I could see somebody very easily starting to walk into a Walmart clinic, know exactly what they're going to pay, and take their care from there.
I mean, I completely agree with that.
This is a side fact about healthcare. You can do anything you want with primary care, and it won't change the cost of the healthcare system. Mm-hmm. It's on the hospitals, it's on the specialties. So we can tinker around the edges with primary care, and we should, but that's not going to take the money out of the problem.
Yes, Walmart, cheaper. Give us something I can get cheaper. But as soon as you send an image over to Sarab and he says, yeah, you got stage 3 cancer, you're in a whole other ball of wax that Walmart's not going to really be able to resolve for you. So, I mean, I think that, to Kim's point, is right. But that doesn't mean that we can't have a ubiquitous primary care platform for everybody that we should demand as being the absolute basic deal, and we may be forced into that, but I mean, it's not clear to me that we are going to get the happy democratic scenario. The scenario Matthew laid out is I've written these 7 little cartoonish scenarios, and I was talking with a Kansas Hospital Association group, and I got them to vote on it. And the scenario they think most likely is the one Matthew described, which is Trump gets reelected with Democratic control in the House, that we kind of go back to a half-baked new normal, but that Medicaid is expanded in some states, and not in others, and it's still very uneven. We get 4 years of whack-a-mole dealing with this rolling virus. It's not exactly a, an uplifting. I'm kind of like a demotivational speaker.
If that
I will be
happens,
emigrating immediately if I can find a place to go, I think.
if that scenario happens, my virtual background is going to become Mars.
So Rob, you got lined up there. Do you want to check? Do you want to add in before we end up?
Yeah, I don't know if these polls are correct, to be honest. And in a sense, it doesn't really matter if they're correct or not, because hospitals either way over the next 4 years will be more screwed than they were before. One of the things that they're not going to be allowed to do is hide their prices. I think
Right.
Bill
That was
was
this week as well. No one mentioned that. That just happened. Yeah.
So things are turning against them, and if you have any form of universal coverage that has anything less than private insurance, that's going to gut their inventories. And if you have Medicaid for all, that's going to be disastrous for them. So hospitals are going to have to think about how they're going to adapt coming in the next 4 years. And I honestly don't think that this administration is necessarily hospital friendly.
Yeah, I mean that's interesting. I mean, I'm really, I know the result of Ian's 7 scenarios, there probably wasn't one where hospitals sort of added massively to those reserves in the next few years, because I mean, if it's the whack-a-mole Medicaid, Medicaid expanded somewhere else, Trump keeps the White House scenario, it's hard to see, unless we have some miracle economic recovery, a way in which we can, you can hit up private insurers plus the employers who pay for it, the way that's happened in the last decade. I mean, we've seen continual massive price rises across the board, and you're right, and that's gone into a lot of places. Hopefully mostly into your pocket, but I suspect a lot of it's gone into admin suites and nice towers and God knows what else. So I think that's probably a place that's not going to be a scenario that is not going to be friendly to the hospitals. And even if we have a more universal platform, Medicare for all, at some point we've got to go after the pricing of the expensive stuff, which is specialty services, drugs, imaging, hospitals and the rest of it. As Kim said, you can do what you like with Walmart primary care, but unless that's attached to some kind of risk sharing or budgeting or price control of something, you're going to just continue to have higher and higher expenditures. And we probably can't afford that unless the Chinese are going to have their own recovery and send us a bigger check, which is really paying for this. Oh, my word. All right.
Matthew, I'm going to have to skate, so I'll maybe.
Okay, can I then force you at the end with your prediction, and then you can skate?
Yeah, no, I just want to follow up on this. We should have talked more about price transparency, but my one thing to watch for is that there are two schools of price transparency. One is that it leads to shopping behavior. My theory is it leads to outrage. And I think you're going to see way more outrage than shopping behavior as a result of transparency.
All right. Thanks, Ian. That's Ian's
I got to go.
For the future,
great to see you guys. We will solve it. We will
solve it eventually. All right. That's Ian's forecast is more outrage from transparency than more outrage from shopping. Zoya, what's your forecast for next week or couple?
Well, I'm really intrigued to see how, just again, like being the resounding millennial sort of younger generation, how they're going to start asking for healthcare, especially with these new distributive services coming out with, removing budgets from policing departments and giving them back. So I'm really interested to see kind of what happens even locally in the Bay, in Oakland and in San Francisco with the redistribution of wealth almost.
All right. We'll see how far that goes. Kim, your forecast for the next little bit.
So next week, the EU is expected to ban travelers from the US. And there was an article in the Atlantic that said the US has been loved, the US has been hated, the US has been feared, but this is the first time the US has ever been pitied. And that should make every American think better.
Absolutely. Jess.
All right, so next week I'm expecting a whole bunch of bad news, because usually, no, truly, all the PR people hang
Sorry, there was good news this week?
No, but worse news. Everybody who's hanging on to layoffs, bad financial reporting, downturn in numbers, anything like that, all of those bad press releases are going to be released the day before 4th of July. That always happens. It happens right before Christmas, right before Thanksgiving. So next week, look out for all of the bad news that's going to be coming.
So there's a lot of bad news we haven't heard about that's going to sneak out.
They'll try to sneak that right through the long weekend. Miss the news cycle.
On the West Wing, they used to call that throwing it out with the trash, right?
Totally. This is like a PR strategy. I've got my eyes open. That's like one of the best days to read stuff.
Saurabh, what's your guess for the next week or two?
I don't know if it's going to happen, but by all projections, we're going to start seeing the deaths rise in Texas, Florida, and everywhere else that where the cases have gone up. I think it's going to be very interesting over the next 2 to 3 weeks to see if that happens or not. And I hope for the sake of the country it doesn't happen. It won't be it's not nice told you so movement, but if it won't happen, if it doesn't happen, if there is no New York or New York light, it probably means that that amongst other things, the hospital capacity is getting better and better at dealing with COVID-19.
Yeah, and we can see right now that certainly Houston, I hear that's getting very close to being a New York type situation, that with that huge medical complex they have down there. And I think you're right. We're going to have to see what happens in that time. Vince, I think you're the last one for your forecast for next week.
Hey, I'm going to flag a scenario for us to watch for and hope for, fueled by two converging trends. The scenario, I'm going to call it the rationalization of healthcare policy towards COVID. Two things are happening, as Kim and Saurabh have pointed out. The numbers are undeniably going in the wrong direction in the last week. And the other trend is that the support of the president and the lack of a coherent policy are going down. You know, we saw the rally in Tulsa where the stadium was empty. What we are seeing is Republican senators and state governors now taking opposite stands. And will we see that en masse? Will we see state policies? I don't think we're going to see lockdowns, but I think we're going to see rollbacks of the phasing, and we're going to see more mandatory mask wearing. And again, I label that the rationalization of health policy. I'm hopeful.
All right, so Vince, I'm going to leave on that note. While Vince is hoping for rationality in health policy, that'd be the first time in about, I don't know, 200 years. So it'd be a good one. And with that, we are out. It's the end of the THCB gang. I want to really thank my guests. That was a great, robust, and fun conversation. We had heard from a person who just skipped at the end there, was Ian Morrison, health futurist from Menlo Park. Jess DeMassa, WTF show, WTF Health host, and my colleague on Health in 2.0. You should always watch that. And hopefully there will be some deals to talk about in the future so that Jess and I can keep doing that other show. Vince Carradis, Grand Poobah at Better Health Technologies. Zoa Khan, my colleague at THCB, editor-in-chief there. Saurabh Jha, the road grad professor at UPenn, coming in from his dark room, although lighter than the room he's used to. And Kim Bellard from the world of health plans and formerly at Tincture Health and now regular contributor to THCB. That's the THCB gang for the 25th of June. We'll be back next week with some special guests. Same time, same place, 1 p.m. Pacific, 4 p.m. Eastern.